Okay, we are back to round out talking about Olicon Chapter 3, Section 1, which is other papulosquamous dermatoses. So you might be wondering, what does papulosquamous even mean? So this is based on the classic reaction patterns in dermatology for classifying rashes. So you have papulosquamous, eczematous, vascular, dermal, and vesiculobullous. So papulosquamous is like psoriasis is the prototypical one. So it's those well-defined red pink brushes that have scale. Okay, perfect. So again, if things are highlighted, that means it's high yield. So what is the most likely diagnosis here? So there's red, orange plaques that are coalescing with some islands of sparing. So that's the buzzword for pityriasis rubra-pilaris or PRP. So you get these orange to salmon plaques with islands of sparing. You get these folliculocentric papules that are kind of like the nutmeg grater papules. You get scalp erythema with scale. You get orange, red, waxy keratoderma on the palms and soles. And you get nail changes, but there's no pitting. So that can distinguish it from psoriasis. Perfect. What gene has been implicated in PRP? This is card 14 or SORS2. So if you've heard of the card 14 papulosquamous eruption in kids or CAPE, that has like a PRP kind of rash, and that's associated with card 14. Okay, so now we're going to match the different types of PRP to their clinical features. This is hard, and I always forget these. So type 1, which one is that? That's just like your classic PRP, most common, 80% self-resolve. Type 2 is also in adults, and you see ichthyosiform leg lesions, keratoderma, and you may see hair loss as well. Type 3, which one is that? So this is like the classic form, but it's just in kids instead of adults. Type 4, also in kids. This is the more common kind in kids. You get localized follicular papules and erythema at the elbows and the knees. Type 5, again in kids. First few years of life, you get pure P and sclerodermoid changes of the hands and feet. And then last but not least, type 6 is generalized, seen in HIV patients, and it's associated with the follicular occlusion disorders of HS and acne conglobata. Type 1 and 3 pretty much self-resolve. The other ones are less likely to self-resolve and persist longer. Okay, what are the histopath findings in PRP? They're pretty classic, but when you see it in real life, it's confusing. So you see a checkerboard pattern of alternating vertical and horizontal ortho and perikeratosis. You see follicular plugging, you see shoulder perikeratosis at the edge of a hair follicle, and then you see a regular acanthosis. So I didn't know if I had a picture. So I'll kind of draw some of these things out. So this is your epidermis. So you have that more irregular type acanthosis, not like psoriasis. And then if this is your stratum corneum that I'm drawing now. Beautiful, I know. And then I'll change the color to show you how the parakeratosis is alternating horizontally and vertically. So you might have some parakeratosis here, then some parakeratosis up here, then some down here. So it's forming like a checkerboard like pattern. This can sometimes be hard to pick up on clinic, like when you actually see it. But that's what they're referring to. And then you might see it like at the edge of a hair follicle here too. Um, so yeah, that's like the classic path findings, but it is that acanthosis that you usually see. What is the first line treatment for PRP? So oral retinoids, so isotretinoin or acitretin. There are some other options. People are trying to use biologics for this and phototherapy, but that can also cause flares. If you have type 6, the one that's associated with HIV, antiretroviral therapy may help. Okay, what contributes to the development of sebderm? You see this in clinic all the time, and you tell them it's related to Malassezia furfur. So the sebum composition is altered. as well. And then you have immune dysregulation too. But it's really that malassezia furfur and like the reaction to that. What are risk factors for subderm? So there's a couple of conditions that you see extrude like more exaggerated subderm, and that is HIV and Parkinson's. Um, I don't really know why, but that's just a factoid that you should know. How does subderm present in kids? So this is like your cradle cap in infants. So this is on the scalp, face, post-auricular area. It can be like at the body creases too, like the sides of the neck or the axilla. But this should really only be in infants. Like kids that are like 3 years old should not be getting subderm. And then if they do have it, you should be thinking about tinea capitis. How does subderm present in adolescents and adults? So you probably see this all the time. So you have well-defined pink patches with greasy scale and sebaceous areas, so scalp, eyebrows, nasolabial folds, the ears, central chest too, and it's usually itchy. And this is like dandruff. What are the histopath findings in subderm? So you get two regular acanthosis, spongiosis. You can get that shoulder parakeratosis at the edge of hair follicles. It can kind of mimic psoriasis, like it can sometimes be in the psoriasiform dermatitis, but it can also be more spongiotic sometimes. What is the gold standard in treatment of subderm? So topical azoles, we're doing the ketoconazole shampoo, the ketoconazole cream. Other options are cyclopirox, corticosteroids to help decrease inflammation, selenium sulfide, other shampoos, but ketoconazole is kind of the gold standard. Okay, what is the best diagnosis for this rash? So this is what they call like the Christmas tree pattern, and I think what they mean by that is like branches and following like the lines, the embryologic lines. So this is Pityriasis rosea. It starts with the Herald patch, which is like the bigger one. And then you get multiple oval patches and plaques on the trunk and extremities along Langer's lines. That's what I was thinking of. And then some patients are really itchy with this. And with the Herald patch, it has a trailing color of scale, meaning like you have your Herald patch and then the scale is trailing behind, so it's more on the inside here, versus leading scale is like going out ahead of the erythema. So that's what trailing is. What are triggers for pityriasis rosea? Most commonly HHV6 and HHV7, but it can also be drug induced, can be caused by ACE inhibitors, gold, beta blockers, those are the main ones. And this is usually seen in younger people, so 10 to 35 years old in the spring and fall. What are other clinical patterns that you can see in pityriasis rosea that are not classic? So you can see inverse, so it can be more in intertriginous areas or more on the limbs. It can be more papular, vesicular, or chargatoid. It can have significant oral involvement, and drug-induced forms can be more itchy, and they cannot have the traditional Herald patch, just have like the smaller plaques. What are the derm path findings in pityriasis rosea? So this has the non-adherent thin mounds of parakeratosis, spongiosis, red blood cell extravasation, and a perivascular infiltrate. So don't bank on the red blood cell extravasation because you can see that in a lot of other things. But this is something that can point you towards this. So here we have a little picture from Visual DX. So you have parakeratosis here, you have your red blood cells. This is a good place where you can see the spongiosis. You see those spaces between the keratinocytes, and you see the perivascular inflammation. This can sometimes be confused with guttate psoriasis, but that has like more like mounded parakeratosis and like thicker. more adherent. It's adherent versus in PR, it's not adherent. What is the treatment of PR? So, first of all, you don't need to treat it, but you can use topical corticosteroids or oral erythromycin, and you can do narrowband UVB if it's persistent. Okay, what's the best diagnosis here in this axilla? So this is granular perikeratosis. They used to call it axillary. I think they're kind of getting away from that because you can see it other areas. So these are itchy red-brown papules and plaques in intertriginous areas. It's usually in adult women, and it may be related to an issue with filaggrin metabolism. What are the histopath findings in this? So the main thing is you see these retained keratohyalin granules in the stratum corneum and perikeratosis. Um, and here is a picture where you can see that the granules are up in the stratum corneum, not where they're supposed to be, but you have a normal granular cell layer still. Perfect. Okay, what can cause erythroderma? There's a lot of things. Some people like the mnemonic id scalp. So it can be psoriasis, which is the most common in healthy patients, can happen after you stop corticosteroids. It can be atopic derm, drug reactions, idiopathic, CTCL, PRP, graft versus host disease. It can be related to lymphoma or other malignancies, chronic actinic dermatitis, ichthyosis, a lot of different things can cause it. I think if we're talking id scalp, the I is idiopathic, D is drug, S is subderm, I want to say. C contact dermatitis or CTCL. A is atopic derm. L is lymphoma. And then P is psoriasis or PRP. I mean, I'm probably missing some of those, but that's the mnemonic that some people like. Okay. Oh, here it is. So I shouldn't have tried so hard. So infection too, and what other ones did I miss? Scabies. So primary erythroderma involves all of the skin in days to weeks, versus secondary is generalization of a more localized skin disease. Okay. What drugs can cause erythroderma? Allopurinol, sulfa drugs, anti-epileptics, which are a common culprit of many rashes, and then antiretroviral therapy too. What is the criteria for diagnosing Sézary syndrome? So the main thing is that you need to have T cell clones in the blood, and then one of the following. So over 1,000 Sézary cells per microliter, a CD4 to CD8 ratio of 10 to 1, or an increased percentage of CD4 cells with the loss of CD7 or CD26. So I feel like the main one that they test about is the over 1,000 Sézary cells per microliter. That's like the main thing that I've seen when I've done practice questions. Okay. How does erythroderma present? What percent BSA does it have to be erythroderma? So it's erythema and scale involving over 90% of the body surface area. And it can be itchy, like hennified. You can have nail changes. You can have secondary bacterial infection. You can have lymphadenopathy with this. It can cause like some of the chronic inflammation issues like anemia. And you can have issues regulating temperature too. Okay, what's the best diagnosis for this? This is CARP, also known as confluent and reticulated papillomatosis. So you get red to brown raised papules that then kind of coalesce to form a reticular pattern. And it's frequently at the chest. What are the histopath findings in this? So it's kind of like acanthosis nigricans. You get hyperkeratosis, acanthosis, and papillomatosis. How do you treat it? What's the first line treatment? Minocycline is the go-to, 100 milligrams twice a day for 6 weeks. But there are other options like oral retinoids, oral antibiotics, and then ketoconazole shampoo as a body wash. What is pseudoatrophoderma coli? So this is a variant of carp on the neck. It's usually vertically oriented hyperpigmentation with wrinkles, and this also responds to minocycline. Perfect. So that's it for this one, and we'll come back with another one soon.